Good. So we'll talk briefly about hypertrophy. Um, so what are potential causes of cardiac hypertrophy?
Mm, IDM,
So infant of diabetic mother.
genetic disease,
What?
genetic disease, like glycogen storage disease or
Yeah.
something.
So one of the common one is Pompe disease, which is
Hmm.
can get very, very hypertrophic. Typically, left ventricle more than the right ventricle, but right ventricle also can be very hypertrophic. And then Pompe disease, typically they will declare themselves with mostly hypotonia that tends to become worse. And typically their hypertrophy comes kind of more obvious at the age of like 1 to 3 months. So it's very rare we'll see them in the neonatal period, actually. It's often kids who will be picked up by, their family history or because there's a metabolic profiling that's been done on the patient or because they declare themselves by arriving um, much later in life, like at 2, 3 months, with already significant hypertrophy. So it's rare we'll see them in the NICU actually with hypertrophic cardiomyopathy, but there are other So yes, you always search for that when you have glycogen storage diseases for sure. Or you look for glycogen storage diseases if you have an unexplained cardiomyopathy with hypertrophy component. What other types of genetic conditions that we'll see more commonly us that can cause hypertrophy?
Not sure.
So Noonan syndrome is something
Oh,
that you need to
okay.
rule out when you see hypertrophy, right? Because they can have like some degree of cardiomyopathy. They can also have isolated heart failure, or they can have other types of cardiac defects. But, if you're not sure, like if you go here, I've put a little summary under genetics. So if you open here, you will go, just going to close some of these. So you'll have some of the manifestation of some of these genetic defects. I think I've put Noonan, maybe not. Yes. So common cardiac anatomic lesion are obviously pulmonary outflow tract and RVOT issues, PDA, VSDs, ASDs, TOF, but they can definitely get hypertrophic cardiomyopathy. And that could be quite severe. Did I put other hypertrophic? Yeah, and so neurofibromatosis, but it tends to be later. Pompe disease, we mentioned it. Hurler syndrome can have hypertrophic cardiomyopathy. And then obviously, infant of diabetic mother. And that's because of
Mhm.
insulin, because insulin is an anabolic hormone. That's why bodybuilders will drug themselves with insulin. And one of the effect of this anabolic hormone is that it can cause hypertrophic cardiomyopathy. And what is the typical area of the heart that gets more hypertrophied in infant of diabetic mother?
Septal part.
Yeah, it tends to be more the septal, but it could be, throughout the heart that they get hypertrophic cardiomyopathy.
Can you explain why it's more the septum
It's
than
a
the
very good
ventricle?
question. I'm not sure actually. I'm not sure
Okay.
why it's more the septum. But that's something you can look for and let me know if there's art.
Yeah.
It might be because of the type of cells that are at the septal level, which are not exactly necessarily the same as the myocardial cells that are components of the free walls. But I'm not 100% sure why particularly the septum is more affected. It might be also related to how the coronary perfusion is happening, or the way that there's excitation of the septum compared to excitation of the free wall and consumption of like glucose and insulin and things like that. So that is a very good question, but I'm not 100% sure why exactly. The reason I'm mentioning the septum is that as the septum becomes thicker, it can cause some degree of obstruction to the left ventricular outflow tract. That's one of the main concerns we have with hypertrophy. Versus, a patient who's on high dose steroids will tend to be concentric hypertrophy, and they
Mhm.
also get often papillary muscle hypertrophy in patients with steroid exposure, neonatal steroid exposure. Now, one of my question And obviously that's what we're looking for, right? There's like signs of alveolar tract obstruction. So we want to spend time looking at the alveolar flow tract. We want to make sure there's no acceleration of flow. Um, Turbulence. So often you see like here, there's like intracavitary turbulence. Why? Because you get all of these muscle layers that become hypertrophy. So you get intracavitary turbulence, like all these vortex of flow will start like spinning inside the left ventricle or even the right ventricle. You can get significant RV hypertrophy too. So, and then you can start having also mitral insufficiency because the pressure rises and you have some component of LVOT obstruction. So blood flow is not able to eject by the outflow tract. So because the pressure inside the heart becomes very, very high, it can cause a bit of avulsion of the mitral valve. So you can get mitral insufficiency because of that. And so in our preemies, if they have a very large PDA, the left ventricular preload becomes higher, right? So you get more pulmonary blood flow, you get more left atrial blood flow, and that increases the left ventricular preload. And so sometimes when there's mild hypertrophy, it can become more difficult to kind of assess the thickness of the muscle just because the muscle is kind of stented by the blood flow, right? Because any balloon, any structure that you're going to inflate more, the wall are going to become thinner. And if you have less preload, the wall is going to look bigger. So other things that can cause cardiomyopathy or hypertrophic cardiomyopathy, like you have to think of twin-twin transfusion syndrome. They can have loading conditions that have made the left heart become more hypertrophied or more dilated, especially the receiver will be more dilated. Um, Situation where you have so severe can look like this. So you see here, you barely have any passage. So that's like very severe cardiomyopathy or hypertrophic cardiomyopathy. There are other elements that can cause hypertrophy of the muscle. You have to think of situation where you get obstruction, like a blockage, like aortic stenosis, coarctation, um, subaortic membranes. And then you can have hypertrophy because you're exposing the muscle to high pressures. So think of RV hypertrophy. RV hypertrophy could happen because of pulmonary stenosis, RVOT outflow tract obstruction, um, like when you have like tetralogy of Fallot, there's a component of like having the VSD that will make the RV hypertrophied. If you have pulmonary hypertension, you can have RV hypertrophy. Same thing if you have very, chronic systemic hypertension, your LV can remodel and you could develop hypertrophy. And that's why in systemic hypertension, that's one of the reasons why they get more at risk of like ischemia, because suddenly you need more coronary blood flow to sustain the LV hypertrophy, because now you have more muscle basically to oxygenate. And so you are more metabolic demand, but these patients have vascular stiffness and they may have coronary artery disease, and suddenly they need to feed more muscles because the muscle has adapted to counteract a hypertensive situation. So that's why hypertension adds on to the burden of heart conditions in adults. And in babies with BPD, we know that they're more at risk of developing hypertension because they probably have some degree of renal disorder, they have acute kidney injury, they have systemic vascular resistances that are higher, so they can get hypertrophy of their heart. Also, stressful situation may lead to some degree of retention of like hormonal things and hormonal byproducts in the heart. And so it's very common, or it's not uncommon, I would say, that in patients with HIE and that have like this adverse transition to postnatal life, they may have some degree of like RV hypertrophy that tends to get better in time. And I don't think it's well described, but my feeling is that it's because the fact that they live this stress, they get like muscle edema, RV edema. The RV doesn't remodel quickly after birth. So kind of these reasons. And probably there's preload changes that makes that the muscle looks thicker on echo in general. So the impact of having RV or LV hypertrophy is it a systolic function problem or a diastolic function problem?
Diastolic. function problem.
Right. It's because this muscle that's very thick is not able to relax nicely. And because it's not able to relax, you're not able to fill appropriately. And because you're not able to fill appropriately, you get basically a restrictive physiology. So if you look at the LV, the issue is that you're not able to get sufficient preload. And secondary to that, your left atrium may have difficulty emptying into the left ventricle. And because it has difficulty emptying in the left ventricle, basically you're either going to get into a situation where you have left atrial hypertension, which can reflect into the pulmonary vasculature by increasing venous drainage. So these are situations that can be complex to manage if they have quote unquote pulmonary hypertension. It's because they may have a component of high pulmonary vascular pressure just because of a post-capillary phenomenon. So putting them on INO could actually worsen them sometimes. So you have to be very careful. If there's a big interatrial shunt that can pop off the left atrium, and you see that it has this like very large left to right atrial shunt, or if you have left to right strict atrial shunt, it tells you the LA pressure is higher than the RA pressure. And if you have signs of pulmonary hypertension, it's kind of an indirect sign that, unlikely this is secondary to pulmonary vasoconstriction. It's more likely that it's secondary to high LA pressure. So I would pay attention to my to my atrial shunt to understand kind of better the physiology. If you have a big ASD, it can really offload your left atrium into your right atrium, and then your LA pressure may not rise. So then these patients may not have signs of pulmonary hypertension, quote unquote, because they're not basically the LA pressure is not rising. The issue they get is that if you get a lot of LA to RA shunt, well, first of all, you're increasing your pulmonary blood flow. So you can increase your QPQS, yes, but you don't get enough blood flow going through your LV outflow tract, basically. Make sense? So you're stealing from your system that way. So a lot of blood recirculates in the pulmonary vasculature, but that's at the expense of LV preload, and so your LV output may drop. So one of the things we'll look at is, first of all, how much am I able to generate in terms of preload? Is it able to relax or not? Am I having, like here you see acceleration in the outflow tract. Am I having blood flow in my outflow tract? So these are definitely things you want to pay attention to when you have these patients with severe hypertrophy. So we'll look at intracavitary gradients. So we'll look at inside the cavity. Is there like, gradient velocities? And then if you have a duct, the duct can inform you on some information. So if you have a right to left PDA, it could also be because you don't have that much output. So you have to be careful. Is it pulmonary hypertension, or is it that I have bad output into my systemic vasculature because my LV is hypertrophied and it's not able to relax and get enough preload to eventually eject. And so these patients, it becomes like a cycle where they may become very tachycardic. And because they're very tachycardic, that's a secondary mechanism to try to increase output. But in a patient who's hypertrophic, if you're increasing the heart rate, what's happening to your filling time?
It's going to be shorter.
It's going to be shorter, so it's dropping.
Yeah.
It's going to make it worse. So these are patients that are very sensitive to two things: preload and heart rate. The other thing is that your PFO, if it's left to right, you could get a Doppler through it and get a sense of the gradients through the Doppler. So if you get a pulse wave or a continuous wave Doppler through your PFO, and it tells you there's very high velocity, it tells you the LA pressure is much higher than the RA pressure. So it informs you on the pressure of your left atrium. So it's a good way. That's one of the things we don't typically do all the time on like our standard protocol. But if you have hypertrophy, it's something I would probably check. Like if I'm able to get, is it like low velocity, like 2-3 millimeters gradient, or is it like 10-15 millimeters of gradient by Bernoulli equation? So when you have hypertrophy, you want to look at obviously your cardiac contraction because some of these patients may be asphyxiated, as I mentioned. You want to look at whether or not you have opening and closing of your aortic valve and that you have blood flow going through your outflow tract and feeding into the aorta. You want to check the septal motion relative to your mitral valve. So we know that the mitral valve is, where do I have an M mode here? Do I have an M mode? I think I do. I think in here. Yeah. So relative to the M mode, we know that in systole, the outflow tract, the apex to outflow tract area is supposed to be like a nice corridor that's well open because blood flow is swirling, right? If I go to the apical view, in a normal situation, if you look at like your 5-chamber view, you're gonna have like nice swirling of flow. So you have the LA, blood flow is red because it's entering the cavity, and then boom, you can see kind of almost the vortex entering your aorta. So you get this kind of swirling path, and the corridor is nicely open. There's nothing in between blocking the way of blood flow going into the outflow tract. It's nicely open. And you can see it in the parasternal long axis view also. So blood flow originates below the valve, goes through the valve, and enters your aorta. That's like the normal way. Now, patients who starts having hypertrophy, this corridor may become narrowed by secondary effect where the mitral valve is actually pulled or drawn towards the septum. We call this systolic anterior motion of the mitral valve. It is something that's mostly seen in adult world with the hypertrophic cardiomyopathies, but it's been seen in babies or kids who have like infant diabetic mother, and that can add to the risk of outflow tract obstruction because what happens is that in systole, typically, so if you put an M mode, you see the anterior leaflet of the mitral valve. So you have in diastole the E wave and then the A wave. So early filling phase, you get mitral opening, and then you get another mitral opening during the atrial contraction. So early filling, atrial contraction, and then typically you close your mitral valve, and your mitral valve stays closed during systole and advances a bit into the cavity as the LV contracts. Okay? This mitral valve leaflet is not supposed to come and touch the septum. This is the septum. You can see it's very thick. Here it's actually touching when the aortic valve is open. So in systole, the aortic valve opens. If you're able to generate enough pressure in your LV to go through your aortic valve and go beyond the diastolic blood pressure in the aorta, you're going to open your aortic valve. And so in some patients that have some degree of obstruction, you may have like systolic anterior motion of mitral valve, which be a component of why they could obstruct their outflow tract. We can see some degree. You see like your aortic valve is open here and your mitral valve is starting to get near your septum. So you have some degree. It's not a full SAM, but it's some degree of systolic anterior motion. And often what you get a lot of thickness of your muscle and you get this aliasing in the cavity, which is a sign that there's like some degree of turbulence. The other thing we can measure is we can do a CW through the cavity and then see what are in systole the intracavitary gradient. Or if you get MR, you can do a CW of the MR, of the mitral insufficiency jet. And let's say you get an MR of 120, but your systolic blood pressure is 50. Well, you know that your LV was able to generate a systolic blood pressure of 50, but your MR is 150. So the LV generated the equal to 100 millimeters of mercury more to be able to eject through this outflow tract obstruction. basically. Does that make sense? So often we'll try, if there is MR, we'll try to get the MR to see the degree of how much pressure there is inside the LV. Because if your LV and your aorta are in contiguity and the aortic valve is open, the two pressures should equalize. So whatever you get in your aorta, like 120 millimeters of mercury, should be 120 millimeters of mercury in your LV cavity. And so if you had an MR, you should get 120 millimeters of mercury of LV to LA or something like near that, like 110. Let's say your LV pressure is 5 to 10. Okay. So you should have a CW, a bit like the TR, right? So your pressure through measurement or your estimate via the Bernoulli equation of an MR should be similar to your aortic pressure. If you have a big discrepancy, your MR is 150 and you have 50 of aortic pressure, it tells you that there's an obstruction of about 100 millimeters of mercury somewhere inside the LV secondary to the hypertrophy. So these are things you would look at. You would look at obviously the systolic function as well. You would do outputs to estimate your output at the level of your outflow tract. You would put color to see if there's intracavitary acceleration, which could be a sign of a concern. So here we see that there's a bit of MR, we see there's a bit of acceleration, but we see there's blood flow going inside the LV cavity. So yeah, so these are kind of like the signs you will look for on echo. And then the question is like, what do you do with that? Right? And so that depends really on the clinical situation. You have a nice summary here. I'm not going to get into the Doppler, but there's also like, I mentioned that if you have high LA pressure, for example, you have a very tiny PFO or no PFO, then your LA pressure starts rising, then your pulmonary venous flow can change as well. You're going to get more of that atrial reversal. So during the atrial contraction, you get more blood flow you spend more time with blood flow going backwards inside the pulmonary vein. This is what this Doppler is, this blood flow, the A wave here. So you get pulmonary venous S wave, diastolic wave, and then you can get some reversal of flow. So we measure the duration. If your duration becomes very long, it tells you, oh, there's a problem, there's more blood flow. There's more time you spend in reversal flow inside your pulmonary venous bed, basically. That's another sign that the LA pressure is high. But if your LA pressure is not high because you have a big ASD that's decompressing the LA, you're not going to see that. You're not going to see that. And your patient may still have very low output because everything is going inside the right atrium instead of going into the LV. I know you have to go for your echoes, so I'll just finish by, you'll see these slides on the website, but these patients are very sensitive to preload and they're very sensitive to heart rate. If hemodynamically they're stable, I think what's important is to limit what are the elements that are causing the hypertrophy. So for example, if it's induced by steroids, you may need to consider lowering the dose or stopping the dose, or at least doing a surveillance if you don't have hemodynamics effects. If the patient has other elements that could be causing the hypertrophy to be worse, like let's say it's a patient with pulmonary hypertension, you may need to, help the pulmonary hypertension by treating the pulmonary hypertension if it's RV hypertrophy. If it's a question of infant of diabetic mother, well, they'll often get better at 3 to 6 months of age. It will kind of spontaneously regress. Obviously, these are patients you want to avoid having constant hyperinsulinemic peaks. So if, for example, it's a patient who is currently having hypoglycemias, well, you may consider normalizing the sugar and avoiding like swings of insulin. So maybe this is a patient who's going to go on like IV fluid or even on continuous feeds for a bit to avoid high insulin peaks secondary to high sugar loads. So, things like this that you need to consider to avoid worsening the situation. And then if the patient is, obviously, as I said, they're very preload sensitive. So You may need to consider giving a bit more fluids for some of these babies, especially those like twin-twin transfusion syndrome with some degree of hypertrophy. They may need slightly more TFI than the others without flooding them, because we know we have to be careful about fluid as well. And then if they become very tachycardic and they have hemodynamic consequences, that's where you start thinking about rate controlling these patients. We use esmolol most of the time because it's rapid acting and you can give it IVs. You start it, you stop it, and the effect is immediate. Versus if you give PO medications like propranolol, they have much more long-lasting effects. So typically we'll start with esmolol to rate control, and you want to bring them back to values that are like 120, 140, kind of, instead of having the 180 of heart rate, just so you can spend more time filling. And obviously, if you have more filling, then, Frank's Starling curve tells you you get more contraction, and so you're going to have more output for these patients because you have better preload and of the LV itself. So avoiding anything that can cause tachycardia. So if this patient is very agitated, you may want to decrease metabolic demand and heart rate. So these are patients you want to maybe sometimes they'll get intubated because they're so sick. And so you're taking over the respiratory work by doing that. If they're febrile, you want to avoid fever because that increases metabolic demand. And so you technically need more output for that. And then if they're feeding, you may need to put them NPO and do the work for them of giving them IV sugar and lipids and proteins if they're sick, if they're unstable. And really, it's like that. And your last resort are like if you start becoming very hypotensive and in shock, that's when you start considering giving vasopressors. And the reason you were giving vasopressor is that the idea is by increasing systemic vascular resistance during systole, the physiological rationale is to try to stent the LV outflow tract. And so norepi can be a solution. The issue with norepi is that you can always increase a bit your heart rate with that, so you have to be careful. So sometimes we use vasopressin, which doesn't change the heart rate. As you know, vasopressin can cause issues with sodium, so that's also something to keep in mind. Or sometimes, many in anesthesia, they would just use phenylephrine, which will not change anything to your heart rate and will increase your SVR. So that's definitely like a choice to consider. And then if you're desperate and these are not working, if the baby's a relatively fresh newborn, you can consider reopening the duct. So it becomes like an RV systemic circulation. If it's strictly an LV compartment issue and your RV is doing okay and it's not hypertrophied and you're able to use that as a systemic pump, you can try to reopening the duct to support your systemic circulation while the LV gets better. Like example, severe infant of diabetic mother, and then, has relatively spared RV, you could consider that. Or really if you have biventricular severe hypertrophy, then you have to consider other routes like ECMO, VAD, transplant, sometimes if it's like a cardiomyopathy that's genetic. But typically you would need to also figure out what's the etiology of it before you list a patient like this for transplant. And it's hard to put these patients on ECMO, right? Then you would need to consider other modality of support like VADs, like Berlin hearts and things like that. So, but that would be very, very extreme. Like I personally have never seen a case like this, but there might be centers that have. So this is a nice review here of like some of the medications we mentioned, like vasopressin and phenylephrine. I think there's another that Passini had looked at. And typically, if it's a question of infant of diabetic mother, they tend to get better with time. And usually it tends to normalize by 2 to 3 months. One thing that's very common in patients with hypertrophy or some degree of intracavitary obstruction is that they get these kind of like sawtooth Dopplers, especially at the outflow tract obstruction level. Let me see if I can do I have an example here? I don't really have an example. Uh, it looks like this, kind of boom, boom. Let me see. Doppler outflow tract obstruction. It has this name. Yeah, it looks like this. You see? It has this shape with an underlying other Doppler. So they'll get this kind of sawtooth appearance of the Doppler um, that looks like this. You see?
Mm-hmm.
Like this. They see it a lot in adult. We sometimes see it in pediatric also, in these contexts of hypertrophic cardiomyopathy. So it's an indirect signs of hypertrophic cardiomyopathy. Oh, there you go. They even put the dagger shape
Oh,
it's called. Yeah,
yeah, I think the baby I saw has that shape.
of a Doppler. Yeah, it's very typical
Yeah,
of outflow tract when you start having
I
outflow
see.
tract obstruction. Yeah. So you want to take a Doppler through that outflow tract to measure the degree
Mm-hmm.
of obstruction. Obviously, the worst obstruction is when you have no flow, so it's completely
Mm-hmm.
obstructed, and then you would have just no Doppler, right? So
Mm-hmm.
when you take gradients, it informs you up to a certain point.
Mm-hmm.
Okay, so that was on
Okay.
cardiac hypertrophy. I hope it helped.